Welcome everyone. My name is Dr. Brielle Stark. I'm an assistant professor of speech language and hearing sciences at Indiana University Bloomington. I'm also core faculty in the program in neuroscience and adjunct faculty in linguistics and associated with cognitive science. It all makes sense, these affiliations, once you think about how neuroscience, cognitive science, language go into understanding aphasia, which is a language disorder that commonly occurs after a brain injury, particularly a left hemisphere stroke. We'll talk more about that today. This is a two-part series. This first lecture series will introduce you to what aphasia looks like, how we think about categorizing different types of aphasia, different severities of aphasia, and some of the characteristics of language that associate with these types and severities. The next lecture series will talk more about the neuroscience behind aphasia. This will focus more on the neurobiology of language, so how we think about the topology of language in the brain, how it's organized, and then we'll also think about how the brain organization changes over time after stroke. So how do people with aphasia recover? What happens in the brain? So stay tuned if you're interested in learning more about aphasia. Aphasia is a language disorder that can affect communication. So language and communication are slightly different. Communication is just how well you can convey a thought, and that often involves nonverbal information. You saw me move my hands there, so gesture or body language, some facial cues or perhaps eye gaze, and some paralinguistic information such as me raising my voice to make it seem perhaps like I'm asking a question. Those two together with language constitute communication. So it's a little bit of an argument in the field as to whether aphasia is always a communication disorder, but we do know that it affects language. And on the next slide, we'll talk a little bit more about what I mean by language. So broadly, aphasia can affect one's ability to understand. We think about that as understanding speech or reading silently. Aphasia can also affect an ability to produce language. So when I say produce language, I don't mean the motor process. That is something a little different. We call that speech production. So speech is the motor component. When I say language production, I mean producing the words or sentences that constitute making meaning. Producing language is, we think of it as being spoken, but it can also, of course, be written. And I want us to also consider that producing language and understanding language can occur in individuals who are deaf prior to developing aphasia, which means that production and comprehension of signed languages can also be impaired. Okay, so we've got spoken auditory comprehension, meaning hearing, we've got sign, we've got reading, and we've got writing. So all of these can be impaired to some extent in someone with aphasia. This is going to be a very brief overview of language. Within language, we think about structure and function. The first four that you see on this infographic, which is from the American Speech Language Hearing Association, constitutes parts of language structure. The last one, pragmatics, involves how we use language and how that changes dependent on context, like where we are, dependent on interpersonal factors, like who we're talking to. But the first four, the structure of language, these are typical components that we see impaired in individuals with aphasia. So phonology is the rule of speech sounds. Phonology can be tied to speech production. Remember, I talked about that being a little different with motor components. But phonology, when we talk about language, is the retrieval and the accessing of sounds that we need to make words. Morphology is the rules of word structure. This goes very closely with syntax, which is the rules of sentence structure. So morphology is like adding an ed to a past tense word, right? And knowing to do that appropriately in a sentence. Syntax is making sure the word order is correct and also embedding clauses to make the sentence more complex and often improve its depth of meaning. And the last one on here is semantics. And this is all about what words mean. We often in the field of speech language hearing sciences and often in linguistics too say lexical semantics, meaning the meaning of words, lexical being the word part there. So in individuals with aphasia, they may lose the meaning of words, which can look like when they're producing language, maybe they get stuck and they're like, I just can't think of that word, or they use a lot of pauses, or they use an incorrect word. They can also have impairments of lexical semantics with comprehension. Maybe their impairment from listening is the result of them not being able to attach a meaning to a word that's coming in through their ears. Pragmatics can also be impacted in aphasia. Like this is the ability to shift your language to be appropriate dependent on the situation. Most of what I'll talk about today deals with language structure, which is the first 4 highlighted on here. This is a nice infographic that I made many years ago to just break down the pieces of what goes on when we produce language and when we understand language. And in this case, I'm thinking about language coming in through our auditory system. So in the production side, first we select what we want to say, the meaning, the concepts that we want to convey. Broadly, we call that semantics. We then select the words appropriate to talk about those concepts. That's the idea of lexical selection. We organize those words meaningfully. This is morphosyntax. We select the sounds associated with those chosen words, which is phonology or phonological access. And then the last 2 boxes here are motor oriented. This is all about the speech system. We need to program the articulators, meaning tongue, lips, cheeks, to say the sounds correctly. And then we need to execute. We need to actually move those articulators to produce speech. So those last 2 are actually speech, whereas the first 4 are language. In auditory comprehension, it's a little bit reversed, understandably so. You're hearing things coming in. You're having to differentiate that phonological information and then access the words and their meanings. Now, I realize this infographic looks like all of this happens like in a linear fashion, right? Like one thing has to happen and then another and then another. There's a lot of disagreements about that in the linguistic literature. I don't want to take sides here. I think both an idea of things happening in an order and things happening at the same time have a lot of research backing them. If you're more interested in reading about this, Levelt, L-E-V-E-L-T, has a lot of great theories and research out there that talks more about language happening kind of like it's illustrated here. You know, there's a process that is followed and it's more linear in a row. But then individuals like Dell, D-E-L-L, think more about the spreading access theory where things are happening kind of at the same time. So if you're interested in reading more about those, I highly recommend going to those 2 authors and reading papers from their groups and individuals who are using their concepts. Now that you understand language and what can happen in aphasia, let's talk about how aphasia itself occurs. The most common cause of aphasia is stroke, specifically stroke to the left hemisphere and the middle cerebral artery. I'll show a picture of that in just a second. But aphasia can also occur as a result of other acquired brain injuries. Tumors growing can impact the brain tissue that they're growing around and in by pushing and preventing the neurons from doing their normal communication. And then, of course, if you have a tumor resected, which means surgically removed, that's going to remove brain tissue. And so you may have an aphasia as a result of that. Infection. Encephalitis is a good example of this, which can infect brain tissue in the critical areas we think about as being important for language, which prevents the neurons from doing their usual job, perhaps to the same quality. Traumatic brain injury is another cause of aphasia, as well as a variety of other cognitive impairments like memory loss, attention loss, executive dysfunction. Traumatic brain injury can be open or closed, and that means, is the skull fractured to be open or does it stay closed? Primary damage that happens is, one is diffuse axonal shearing, meaning that the brain moves so much that the white matter tracts called axons actually shear. They can rip completely apart or they can partially tear, and it prevents communication because that's what axons do. They relay information from one neuron to another. When we shear them, you prevent that communication from going. And the other thing we think about with TBI, traumatic brain injury, is coup and contra coup, which is that usually when you hit your head, there's a counter reaction, the contra coup, that also happens. So let's say you hit your head in the front, that's the coup, the first hit, and then your head ricochets back and you hit the back of your head. That's the contra coup, or the second hit. So you can think about the brain being impacted in both of those collisions. And then, of course, there's secondary damage that happens as a result of a traumatic brain injury. Edema, swelling, and infection. So this is what happens when the brain is trying to correct itself, how it's reacting to this trauma, and that can contribute to aphasia symptoms. Some other causes include hypoxic brain damage, which is a lack of oxygen for a considerable amount of time. An example of this might be a near drowning experience. A virus, progressive neurological diseases. Specifically, there is a syndrome called primary progressive aphasia. It's relatively new compared to what we know about acquired aphasia, or the aphasia I'll mostly focus on today. In primary progressive aphasia, these individuals have progressive brain diseases like Alzheimer's disease and like frontotemporal dementia. We call them individuals with primary progressive aphasia because, unlike what we typically think about in dementia, which is a presentation of memory loss or even a personality change, these individuals with primary progressive aphasia have a language impairment first and foremost, and it is the critical cognitive impairment. Over time, they do develop more cognitive impairments, in particular episodic memory loss, meaning kind of the facts about ourselves, our memory about that. But in the beginning, it is a distinct language change, and that progresses over time. So if you're interested in primary progressive aphasia, there's some great literature out there. As of right now, so I'm recording this in 2023, we recognize 3 different variants or types of primary progressive aphasia: logopenic, semantic, and something called non-fluent or agrammatic. So if you're interested in learning more about that, I encourage you to go do some research on those 3 variants, and we are constantly learning more about what their presentation is, what their language impairments are, and how to accurately and diagnose them early as well. The last one I want to mention here is there are some reversible causes of aphasia. One can be a medication. There are some medications out there. An example is one for epilepsy that can cause an immediate change in the ability to produce language. It doesn't happen to everyone. It's pretty rare, but that's a reversible cause because you can switch the medication. Another reversible cause is when major depression disorder, which is the official name for depression, that can look like an aphasia because they may have a real issue producing language. They may have a very much cloudy, they may say that their brain seems cloudy, foggy. They have an issue producing language. And if that's successfully treated with medication or therapy, often the aphasia can resolve. So these are reversible causes of aphasia. What we're mostly going to focus on today is aphasia caused by stroke. Here's an example of some individuals with stroke as well as aphasia. So what you're seeing here on the left-hand side, let me just see if I can get my pointer. This grouping up here is a single person. That's one person, just two different brain views, which I'll describe in a second. This is a single person, and this is a single person. So these brain views on the left, we traditionally call axial or transverse or horizontal images. What they are is a cut going this way and looking down into the brain. So the eyes would be up here and the back of the head is here. This is the left side and this is the right side. Now we love axial images as neuroscientists because we're used to looking at them and they show us a lot of information. But as new users of MRI images, like you, I presume, they're a little bit more complicated to really understand what's going on and where the damage is. So for newer users of, or I should say newer readers of MRI images, these images on the right are a little bit more straightforward. We call these sagittal images. These are taking a side view, so literally a cut like this, and we're evaluating one side of the brain. In this case, you can see the eyeballs are pointing left, the back of the head is here. So these are all individuals where we're only seeing the left side of the brain. Now these types of MRI scans are called T1 weighted images. What that means is the damage caused by the stroke is going to look dark. So you can see up here, I'm just highlighting, you know what, let's see if I can bring my pen. This area here, this dark area, is stroke-caused damage. Let me just do a little highlighting in each one. I'm only going to highlight on the sagittal image since it's a bit easier to see. These are all strokes that involve the middle cerebral artery in the left hemisphere. Now you have a middle cerebral artery in both hemispheres. It's your biggest artery branch in the brain. It comes from your carotid artery. Middle cerebral artery strokes can be smaller or they can be very large. Typically, the larger strokes are the ones that result in aphasia, but that's not always true. But these individuals, you can see this middle individual has the largest amount of tissue damage from stroke. This individual has a considerable amount too, and this individual at the bottom has a comparatively smaller amount of damage. But all of these strokes have involved the middle cerebral artery. Detailed view of the middle cerebral artery. This image at the bottom is a cartoon image of a sagittal slice of the left hemisphere. In pink is the area of the brain that's served by the middle cerebral artery. Now this is only a lateral side view, meaning that we're not seeing the middle of the head here. We're seeing mostly the outside of the head. The middle cerebral artery does serve mostly the outside, or what we call the lateral cortex of the brain, but there are parts of the middle cerebral artery called the lenticulostriate arteries that do serve parts of the middle, more toward the, we call it medial section of the brain. But typically aphasia is the result of cortical damage, meaning outside lateral damage. This is a coronal slice showing the middle cerebral artery, so I can talk a little bit more about outside versus inside, or what we say is lateral versus medial. Coronal slices cut the head like this, coronal meaning crown, and so you've got a top and a bottom that are the top of the head and more toward the body. So this is the top of the head, this is toward the body. These little structures you see on the side are the temporal lobes. And this up here is frontal and parietal lobes. Let me show it to you on the sagittal slice. This is your temporal lobe. This is your occipital lobe. Here's your parietal lobe. And here's your frontal lobe. You can see the middle cerebral artery on this coronal slice is huge, goes through a lot of the brain. These are the lenticulostriate arteries that serve the middle of the brain. But this big artery system right here serves the outside cortical areas of the brain. Some of us like to think about this as being the inferior division, which means serving the temporal lobe. and the superior division, meaning serving the parietal and the frontal lobes. So on the sagittal image, this would be the inferior division of the middle cerebral artery, and this would be the superior division of the middle cerebral artery. When someone has a stroke, it is a damage to not just a single area of the brain, but usually quite a few different areas, which I hope you can understand how that happens given this image of the artery system up here. Let's pretend just for 1 second that we have a clot, and I'm going to make the clot orange here. Let's pretend we have a clot that gets stuck right here. What is going to happen is that blood flow beyond the clot, meaning all of this and all of this, is going to be reduced or completely cut off. In this case, the stroke is going to affect both the inferior and the superior territories of the middle cerebral artery. This would be a very large stroke if the blood clot happened there. Now, it doesn't always have to be a clot. It can also be a bleed, which I'll mention on the next slide. And they both cause considerable damage, and that depends on where the damage happens. So where the clot gets stuck or where the bleed occurs. You might understand, let me erase this one here. You might understand, in fact, that if the clot is small enough and it travels quite a good distance and it just gets blocked right up here in the superior division, you are just going to have stroke symptoms as a result of damage to a relatively smaller section of the superior MCA. So it really depends on where the stroke happens, on what section of the brain is impacted, and how much of the brain is impacted. This is a graphical illustration of an ischemic or a clot or a thrombus-based stroke on the left and a hemorrhagic on the right. Two causes can result in an ischemic stroke. Ischemic literally means a blockage occurring somewhere. So in the left image, you can see they have the word thrombus. Thrombus usually means the closing of an artery. For example, cholesterol might build up so much that it just closes off that artery. That's a thrombus. An ischemic stroke can also happen as a result of an embolism, which is a clot thrown up into the brain from elsewhere, usually from the heart. Both of those constitute a blockage, which then results in an ischemic type stroke. Ischemic strokes are much more common than hemorrhagic strokes. I think 80 to 85% of strokes are ischemic. Hemorrhagic strokes are a bleed or a rupture of a vessel. This can happen for a variety of reasons, like a weakening of the vessel wall, something like a trauma, like if you, sometimes it's called a dissection where the artery itself gets cut by some event, and that causes a bleed, and the bleed overwhelms the brain tissue around it, which doesn't allow that brain tissue to use its oxygen as normal, so it causes a stroke in the area affected by the bleed. Here's just a few facts about stroke from the Center for Disease Control in the US. Stroke is one of the leading causes of disability. It actually might be, I do have there on number 4, it is the leading cause of long-term disability in at least the United States. Disability meaning something like aphasia, but can also mean a physical disability, for example. Stroke can reduce mobility, meaning it can cause a physical change in more than half of the people who experience stroke aged 65 and older. Something I want to mention that's not on here is that there is an increase in the number of individuals who are having strokes earlier in life. There's an increase particularly in strokes occurring before the age of 45. Again, I'm recording this in 2023. We're still trying to figure out what's causing this change, because in past years, we've always thought about stroke and aphasia being a disorder, aphasia being a disorder that affects older adults, and that's just not true anymore. So what we're thinking about now is that people can live with aphasia for upwards of 30 to 40 years. And so we really, as people who study aphasia or treat aphasia, we need to take into account that we are going to we're going to have to advocate and provide services and even change our service model to make sure that these individuals can still receive language therapy, for example. So we're going to have to make a lot of changes in our healthcare and our rehabilitation systems to accommodate this new rising rate of stroke and aphasia in the US. Now, I do want to say, in general, rates of stroke have gone down steadily since about 1990. That's because our medical system has gotten better at treating stroke. And in general, the public is more aware of stroke. People are often taught the acronym FAST, meaning face. If your face droops, that's something that should immediately indicate you need to get this person help for a stroke. The second letter in FAST is A, meaning arm. Does your arm lose its mobility, become really weak, something like that? That's a stroke sign. S is speech. Do they suddenly start slurring, forgetting words, unable to understand you? And T is time, meaning that you act fast. As soon as you can get this person to the hospital, the better. The stroke outcomes are much better for people who get to the hospital fast. In the USA, right now, we think that there is about 2 million people living with aphasia. Now, most of these individuals have acquired aphasia as a result of a brain injury like a stroke, but there are a considerable number in there, a growing number, that have that primary progressive aphasia that I mentioned earlier. That's the result of a neurological progressive disorder, such as Alzheimer's disease. 2 million is a big number. This is actually a higher prevalence rate than other disorders that are more commonly known. For example, Parkinson's disease has about 1 million individuals affected in the US. When someone has a stroke, about 1/3 of those will result in aphasia. Of those individuals, 2/3 will actually have that aphasia go away within a few days to weeks. We call it spontaneous recovery. But that means the 1/3 that has aphasia in the beginning will keep having aphasia. And we call those individuals individuals with chronic aphasia. It persists past at least 6 months and typically continues to persist. They can improve, but they will have aphasia for their life at this point. This is my last slide before we jump to the next lecture series, which is more on understanding types and severities of aphasia. I want to end with saying that while aphasia is a language disorder, it often does not exist in a vacuum. Other things are present, usually because of the social isolation and the impairments of communication that often coincide with aphasia, as well as the loss of friends or family because of the massive life change that a brain injury causes. Depression is pretty common in aphasia. I saw a recent statistic that someone was estimating about 30% of people with aphasia may also have depression. The onset of aphasia after brain injury is sudden. It is a complete change in how you've lived your life, and since aphasia affects adults primarily, these adults have been used to living their life in a certain way, and this change is completely sudden and often brings up many feelings related to grief, frustration, anger. And so recovering one's identity, recovering what one is able to do for work, for participation, what activities they can do, who they want to and can communicate with, is a conscious process that has to happen after this very sudden change. The third bullet point echoes what I said in the last slide, which is that these individuals with chronic aphasia can have aphasia for a very long time. It will continue to, or it can, I should say, continue to improve. And I have more information on that, I believe, in the next lecture series. And 10% we estimate right now have that primary progressive aphasia type. That might be a percentage that changes as we learn more about that type, and also as we get more sensitive assessments that can identify those people a bit earlier, because that's something that's not currently, we don't really have best practices for yet. If you have questions on this presentation or any material in it thus far, please feel free to reach out to me. My email is listed below. I also do a lot of research involving individuals with aphasia. We typically look at language as well as communication and nonverbal communication, things like gesture, and my lab also evaluates inner speech, or this inner experience of talking to ourselves in our heads, what that looks like in individuals with aphasia. So if you're interested, you can check out my website, and I hope you continue on with this lecture series.